Hello, my name is JMcGlone, and tonight I'm going to be defending my thesis. The title of the thesis is Altering Gambling Behavior Through Probability Trading. First, I wanted to acknowledge Dr. Dixon and Jacob Dar for assisting in some data collection and answering all the questions that I've had along the way. So over 30 years ago, gambling was only legalized in 2 of our 50 states. However, currently it is legalized in 48 of the 50 U.S. states. More than $500 billion are spent annually on wagering. So as Meyer found that overall Canadians' views and attitudes towards gambling are less a serious problem than other issues, including drug use, alcohol addiction, smoking, and driving over the speed limit. So just some types of gambling that are available. There are casinos, instant lotteries, dog and horse, often on-track betting. A plethora of internet gambling has shown up, and live video gaming is now found in gas stations, grocery stores, bars, strip malls. Also, there are raffles, sports betting, bingo. So some contributing factors to gambling is that Welch, Barnes, Tidwell, and Hoffman found that males are more likely to gamble than females. And as the socioeconomic status decreases, the prevalence of problem or pathological gambling rises. At a West Virginia gambling health hotline, they found that more females actually call the center. However, more males actually attend the suggested counseling sessions in person. According to the National Gambling Impact Study that came out in 1999, 7.5 million adult Americans fell under the category of problem or a pathological gambler. Even more alarming is the numbers of the adolescent pathological or problem gamblers, and they're up to 7.9 million. Since 1980, problem or pathological gambling has been included in the Diagnostic Statistical Manual, the DSM, recognizing that this definitely is a psychiatric disorder. So what is the reality of it all? As with most therapies, patients are in search of quick fixes. They want to find some relief from the stress, harm, and ruin that their behaviors cause them and their loved ones. However, reluctance to commit to lengthy and costly treatment prevents the patient from achieving their desired long-term outcomes. To date, there's no single treatment or therapy that has proven to assist individuals with problem or pathological gambling to maintain abstinence from gambling on a consistent basis. Burge, Petruk, and Petrie reported that early onset of problem or pathological gambling often coincides with suicidal ideation, alcohol use, and prior substance abuse treatment. Griffiths found that regular and pathological gamblers were more likely to report negative moods before and after gambling than non-regular gamblers. Donati, Chiesi, and Primi found that adolescents who have a parent with gambling problems are 7 times more likely to develop gambling-related problems in their early adulthood. And prevalence in adolescent gambling, according to Vacron, Viatro, Weiner, and Tremblay, is due to and linked to poor parental discipline, including decreased monitoring, and disciplinary strategies. So the early treatments for gambling problems included aversion therapy, and then it was moved to desensitization, where therapists would present a typical anesthesia stimuli to gambling and pair with this a relaxation training. More recently, on the scene is cognitive behavioral therapy, acceptance and commitment therapy, and the McGill treatment paradigm. So in detail, more specifically, cognitive behavioral therapy, or CBT, is currently the most used therapy for psychiatric conditions, including addiction disorders. Psychotherapy. So it's a type of psychotherapy. However, it's unlike the traditional psychotherapy treatments. This includes active participation between the patient and the counselor or therapist, and it examines the relationships between thoughts, feelings, and behaviors. ACT, or acceptance and commitment therapy, on the other hand, it also does not focus on abstinence. The treatment focuses on moving through 6 psychological processes, and the 6 include contacting the present moment, diffusion, acceptance, self as context, values, and committed action. However, the McGill treatment paradigm is typically used in therapies and treatments for adolescents, focusing on abstinence. So there are quite a bit of harms related to problem pathological gambling. So with adolescent problem gamblers, they're more likely to report in school truancy, having difficulty in school, and experiencing financial and or personal problems. Adult problem gamblers have shown evidenced higher rates of depression, anxiety, substance abuse, marital discord, domestic violence, bankruptcy, criminal offenses, lost productivity, and or suicidality. So some previous research associated with gambling includes a study by Whiting and Dixon in 2013, and they examined the effects of mental imagery on the desire to gamble. So the control group imagined gambling on a slot machine 3 times, and they actually put quarters into a laundry machine 30 times. The experimental group imagined gambling on a slot machine 30 times and put quarters into a laundry machine 3 times. The results showed that the experimental group gambled much less than the control group when they were able to play on an actual slot machine. Walder, Hainwinkel, and Morgenstern in 2013 examined how a 90-minute lesson on gambling, information, and consequences for 6th and 7th graders in Germany affected their knowledge of gambling. So the control group did not receive the 90-minute lesson on gambling, information, and consequences. However, the experimental group did receive this 90-minute lesson. So the results showed that the experimental group showed a significant increase in knowledge and understanding of gambling behavior and the potential harmful outcomes of this risky behavior on the post-test compared to the pre-test answers and the control group. Turner, McDonald, and Bartoshuk and Zangine in 2008 examined the effects of an hour-long prevention program on students in grades 5 through 12 through the pre and post test results. And so the control group did not attend this prevention program, and the experimental group did. And with the results, the experimental group showed an increase in knowledge of gambling. However, there was no significant change in the participants' gambling involvement, attitudes towards gambling, or any reported problematic behavior. In 2009, Dowling, Smith, and Thomas conducted a study aimed specifically at female pathological gamblers. And the researchers examined two separate treatment groups, the first of which was abstinence from gambling, and they had a group for this and individual sessions, along with the second treatment was using CBT with also they had group and individual sessions. So the abstinence group, they attended the 12-week group and individual sessions, focusing on abstaining from gambling altogether. The CBT group attended the 12 group and individual sessions, focusing on controlling their gambling and agreeing to a certain frequency and expenditure that is acceptable. Overall, the results did not prove one treatment better than the other. During the follow-up phases at 3-month and 6-month marks, both of the groups had decreased the frequency and expenditure of their gambling from the baseline data. However, they both were about the same with the frequency and expenditure. So on a positive note, according to Welch, Barnes, Tidwell, Hoffman, over a lifespan, problem or pathological gambling decreases. Of the respondents in an 18 to 30-year-old age group, 4.3% were identified as problem or pathological gamblers. However, respondents aged 61 or older, only 1.2% of them were identified as problem or pathological gamblers. So, possible contributing factors to this is the decreasing trends in problem gambling. They believe that it's speculated as a part of the general decline in problem behaviors altogether linked to a developmental effect. So what does this all add up to? My experimental question. Will probability instruction have any effects on bets placed during gambling trials? So for my methods, I had 8 graduate students recruited from a Midwest university. Extra credit was offered for participation in the study. The ages were between 22 to 26 with a mean of 22.7. There was one participant that did not disclose his age. The South Oaks gambling screen was administered, and all participants scored 3 or less. There was a mix of gender and races. There were 6 females and 2 males, with 3 participants identifying themselves as Caucasian, 3 identifying as African American, 1 as Hispanic, and 1 as both Caucasian and Asian. The materials that were used include standard 6-sided playing dice, a croupier stick, a computer, a half Vegas style craps playing table, wagering chips, the SOGs, and the demographic information sheet. So first, the game was explained and participants were shown dice and asked to roll the dice, and the participant in the pair that rolled the highest was the shooter for the entirety of the session. So what they did was they played a simplified craps game. The numbers 7 and 11 won triple their wager, and all other numbers lost the bet placed. During phase 1, it was training, so participants were given 100 chips each, and the participants played 5 rolls, betting between 0 to 3 chips each trial. At the end of the 5 rolls or trials, their bets were returned to them. If a participant had not experienced a win during the training, they were shown how much they would have won on the last roll. So during phase 2, this was our baseline phase, and participants again started with 100 chips. The research assistant explained that the chips they now have are equal to half of the extra credit that they could earn, and if they were to win more chips, they could earn more extra credit, and vice versa. If they lost chips, they would earn less extra credit. During this phase, the number of trials were varying between pairs of participants in the sessions based on the multiple baseline design. So in phase 3, the participants watched a instructional 11-slide Microsoft PowerPoint presentation on understanding dice and how probability works, given the amount of numbers available on the dice. So during the presentation, participants were made aware of the probability of rolling each number, the numbers 2 through 12, and as each possible combination does not yield the same number of chances. Phase 4 was the post-treatment, and so each participant was again given 100 chips. The same instructions were given that were given during baseline. The same number of trials occurred during this phase as they had played during baseline. So there was 75% of the time there was a second observer during the trials and sessions, and the IOA was 100%. IOA was calculated by dividing agreements by agreements plus disagreements. So the results during phase 1 training, the overall average bets for all participants except for participant number 6 during this phase were greater than all other phases to follow for each one. During this phase, there was a consistent increasing trend in the cumulative bets for all participants, and the results of average individual bets, specific average bets during phase 1 are, for participant 1, they averaged betting 2.1 chips per trial. Participant 2 averaged 2 chips per trial, and participant 3 averaged 1.5 chips per trial. Participant 4 bet 4 chips per trial. Participant 5, 2.4. Participant 6 bet 3 chips per trial. Participant 7 bet 1.9 chips per trial. And participant 8 bet 3 chips per trial. The results during the baseline phase, the bets continued to be made, however, the magnitude of the bets decreased significantly across all the participants with the exception of participant number 6. During this phase, there continued to be an increasing trend in the cumulative bets. So what the results looked like in this phase was participant 1 bet an average of 0.5 chips per trial. And so this was a difference of 1.5 chips from phase 1. Participant 2 bet an average of 1.4 chips per trial, and this was a difference from an average of 0.6 chips, a difference of 0.6 chips from phase 1. Participant 3 bet 0.8 chips per trial on average, and this is a difference of 0.7 chips. Participant 4 bet an average of 1 chips per trial, with a difference of 2 chips from phase 1. So the rest of the data looked like participant 5 bet 1.7 chips per trial, and again a difference of 0.7 chips from phase 1. Participant 6 bet 3 chips per trial, and this was no difference from phase 1. Participant 7 bet 0.7 chips on average per trial, which was a difference of 1.2 chips from phase 1. And lastly, participant 8 bet 0.4 chips per trial, with a difference of 2.6 chips from phase 1. So if you recall that phase 3 was the probability instruction during this phase, all that they were doing was watching the PowerPoint presentation. And phase 4 was the post-treatment, where the results varied between individuals once we got to this phase. So the participant 1 bet 0.5 chips on average per trial, and this was no difference from phase 2, however, a difference of 1.6 chips from phase 1. Participant 2 bet 0.8 chips per trial, and this is a difference of 0.6 chips from phase 2 and a difference of 1.2 chips from phase 1. So quite a bit of a difference there. Participant 3 bet 1.3 chips per trial, and this was a difference of negative 0.5 chips from phase 2. So they actually bet more chips on average during the phase 4 than they did in phase 2. However, it still was a difference of 0.2 chips from phase 1. Participant 4 bet 1.4 chips per trial with a difference of negative 0.1. Again, they actually bet more chips during phase 4 than they did during phase 2. However, it still was a difference of 1.9 chips from phase 1. And participant 5 bet 1.1 chips per trial, with a difference of 0.6 chips from phase 2 and 1.3 chips from phase 1. Participant 6 bet 3 chips per trial, and this was no different than phase 2 or phase 1. Participant 7 bet 0.4 chips per trial, so it's a difference of 0.3 chips from phase 2 and a difference of 1.5 chips from phase 1. And lastly, participant 8 bet 0 chips per trial on average. So this was a difference of 0.4 chips from phase 2 and a difference of 3 chips from phase 1. The overall calculated average chips bet for all participants in phase 1 is an average of 2.7 chips per trial. And the overall average chips bet for phase 2 is 1.2 chips per trial. Lastly, the overall average chips bet for participants in phase 4 is 1. So 4 out of the 8 participants showed decreasing betting trends over each of the phases, including decreases from phase 2 to phase 4. 2 participants showed no change in the average bets placed between phase 2 and phase 4. And lastly, 2 participants showed increases in average bets placed between phase 2 and phase 4. So phase 3, the probability instruction impacted at least 50% of the participants in this study. So the results of the study illustrate that at least half of the participants were affected by the probability training that occurred in phase 3, and the greatest impact occurred in participant 8, where after probability instruction was delivered, there were 0 bets placed thereafter in the remaining trials. So a greater impact of decreasing bets were observed between phase 1 and phase 2, actually, when participants were made aware that the chips that they have at the end will be divided in 2 and will account for the extra credit that they earn in their college class. All participants, with the exception of participant 6, decreased the average wager they made in phase 2 when compared to phase 1. So there were quite a few limitations and suggestions for future studies. The first one is that this was a small number of participants in this study, so future studies should have a greater number of subjects, and that may better support the probability instruction as a key factor in decreasing gambling behavior. Secondly, this took place on a college campus with individuals who scored less than 5 on the SOG, so it did not put them in the pathological or problem gambling category. So looking forward, studies might want to look at how this type of study would affect gamblers or people who are identified as problem or pathological gamblers. Another limitation was that the game was played not on a standard craps game table in the casinos, and so the standard game is more detailed. This was just a simplified craps game, so it couldn't account for exact behavior in a typical Las Vegas craps game. Lastly, the results may be confounded with possible competing contingencies of earning extra credit in their college class, so the academic success of each participant in the class where extra credit will be applied has some bearing on how much extra credit they are in need of. If a student is doing poorly in the class and eligible for extra credit, and they believe they can gain more extra credit by increasing their bets, that also confounds the results. I hope you enjoyed my thesis defense. Thank you very much and have a nice night.